Hello everyone and good evening, and it's good to be back once again. Welcome back everyone once again to our Stronger Together live event, and it's good to be back here again. It's a Monday, so I do hope you had a good and busy day, and also you are a little bit relaxed after the weekend and are ready to learn some more from our topic tonight and our new guest that you can see right here. This is Dr. Norman Gomez Diaz. And hi, Dr. Norman. How are you feeling tonight?
I'm feeling good. I'm feeling good. Thanks for the question. I'm excited about this opportunity, and I must say thank to you because all the to solve all the technical problems and to make today's talk possible.
Excellent. We are
So
definitely happy to have you as our presenter. And as you know, we do have an interesting topic tonight. And Dr. Norman has prepared a presentation on reproductive surgery, minimally invasive interventions to restore fertility. And our guest, Dr. Norman Gomez, is actually a gynecologist and also a surgeon at Equipo Juana Crespo, which is located in Valencia. You might be already familiar that we did have a few doctors from Equipo Juana Crespo, so I'm very, very excited to have you as well on board from the team. So thank you so much for joining. And I am your host, Caroline, as always. And as you know, we will start with the presentation. And I also want to thank all our ambassadors and partners for their constant support, and this is ongoing Stronger Together events. And as you know, we will be back here for more 2 weeks, and then we will have a little bit of a break, but I am already happy to be able to share with you that we will be for sure back pretty much soon as well. And as I mentioned, now we will go ahead with the presentation, but afterwards, as always, remember it will be a time for your questions, so just type those in the chat section, and Dr. Norman will simply answer them for you after the presentation. And well, I guess we can now go ahead with it, right? Dr. Norman, ready?
yes, I'm ready. I'm ready.
Wonderful.
So
Thank you.
thanks for the introductions. So as you say, I'm Norman Gomez. I'll be part of the surgical unit of Juana Crespo medical group. So we have a lot of experience in the fertility treatment. We do already 1,500 IVF XC cycles per year. So we have a lot of experience treating patients with fertility problems. And our surgical unit do a lot of surgeries to all the patients that we treat. And today we're going to discuss some aspect about our daily work. Okay, so I always like to start with this slide. I like this slide because this slide summarizes what the equation of pregnancy represents for me. So the first time we have the patient, and obviously her constitution, her body weight is important for us and for the treatment, and all or if the patient have any blood clotting disorders or any autoimmune disorders. So we need to take in account for the treatment. This is a very big aspect to take in account. The other aspect is the embryos. We have the embryos and also the quality of the embryos, and the quality is linked to the age of the patient. So this is important to get pregnant for sure. And finally, the last but not least is the uterine factor. The uterus is the most important organ in the reproductive field. So there's a lot of conditions that can affect the functionality of this organ, this uterus. So it's important to know about this. And today's talk is focused in this aspect, the uterus, and how, from the surgical point of view, we can fix the uterus when it's dysfunctional. So we will talk about that. So for facilitate the understanding of the issues, I always like to divide schematically the uterus in two compartments. The first compartment will be the internal compartment. As you can see, this inverted triangle, it represents the uterine cavity. And we have the external compartment. The external compartment represents the ovaries, both tubes, and also the uterine walls. It's important to keep in mind these two compartments because it will help us to understand which kind of surgical treatment we can apply in each compartment. So that's the reason because it's important to do the distinction about these two compartments. So when we talk about the external compartment, there's a lot of conditions that we can find here in the external part of the uterus. I show you a few examples of the most frequent pathologies that we treat in our daily work. So the first time we have the endometriosis. This is the endometriosis, and this is the uterus affected by this disease. You can see in this uterus ovarian cyst. Ovarian cyst is an endometriotic cyst, and also you can find a lot of adhesions covering the uterus, and all this is conditioned by an inflammatory environment. So we can treat all these problems when we have a uterus with these conditions. And this is very frequent in our daily practice. The second thing I want to tell you is the hydrosalpinx is a condition of the tube, the fallopian tube. So in this condition, the fallopian tube is obstructed at the end of the tube. So when the tube is obstructed, can accumulate liquid inside, and this liquid inside can do that when we put the embryos inside the uterus, can reduce the implantation process of the embryos by a half. The other negative effect of the tubes is that can impair the natural conceptions, for sure, when it affects the tube, and also can produce a pregnancy outside of the uterus, inside the tube. The name is ectopic pregnancy. This can affect the fertility during this kind of problems. On the contrary, when we have this pathology and we do a surgery to remove the tube in this condition, we for sure can improve the possibility of pregnancy in this kind of patients. So that is important to know the status of the tube before start any kind of fertility treatment. And thirdly, we have the myomas, the uterine myomas. Myomas are these tumors, is a benign tumors that is located and originate from the uterine walls. It's a fibrous tissue that grow in the uterine wall, and depending of the size of the myoma and location of the myoma and the amount of this, can affect or not the reproductive process. So for the surgical point of view, we can treat all these problems too. And it's a very frequent pathology, the myomas, because represent 30% of the patients that consult with fertility problems. So we see these problems with many times in our daily practice. So this is the most important pathologies that we can find in the external part of the uterus. From the internal part or internal compartment of the uterus, we can see this normal uterine cavity. We can find also a lot of pathologic situations inside the uterine cavity that we can solve with surgery. I show you the most frequent details about pathologies inside the uterine cavity. There is two kinds of pathologies. One of these is congenital pathologies, like this one. This is an uterine septum. Uterine septum, you can see, comparing with this normal cavity, that this uterus have in the middle a wall that divides the uterus into small cavities, as you can see in this picture. So this is the most frequent congenital anomaly that we can find in patients with fertility problems. Congenital means that the patient born with these conditions, but we can treat that. And also we have acquired condition. Acquired means that the patient do not born with these situations, but develop these pathological conditions during the reproductive life of the women. So we have a few examples, the most frequent for sure. I show you a polyp. This is a polyp, a big polyp in the fundus of the uterus. We have synechia. Synechia is the uterine walls are stick together inside in the fundus. Most of the times relate to a traumatic event inside the uterus, like a curettage for abortion, maybe. It's very related with this. And finally, we have fibroids. Fibroids we can find also inside the cavity. It can affect the implantation process and have all these conditions bad reproductive prognosis. So our job as a surgeon is to transform this kind of uterus with pathologies inside the uterine cavity in a uterus more normal, like this. They correspond with a cavity like this, normal cavity like this. Doing this, we can improve the possibility of pregnancy in these patients. The literature is described that the prevalence of unsuspected uterine anomalies in patients without symptoms is about 10 or 40% of the cases. It's very, very frequent to find something inside the uterine cavity in patients with fertility problems. So we need to have and do a good diagnosis of these pathologies, and we treat with surgery if required, and to get a success pregnancy. Okay, so how can we get to the diagnosis of these pathological situations? So generally we use the ultrasound scan, is the best tool for the evaluation of the uterus. As you can see here, we can see a 3D image of the uterine cavity and the uterine morphology. So every gynecologist have in the practice in office have ultrasound machine, so can assess the patient very well. It's a very, very good tool. For me, it's the best for evaluation of the uterus. And also, we have the MRI. The MRI is a very good tool. Also, we can not only evaluate the uterus, but also all the pelvis. All the pelvis, we can see the lateral wall of the pelvis and the outside part of the uterus. It's very, very good tool too. We use a lot the MRI scan, especially for surgical planning. So all these techniques allow us to get more information or more details about the pathologic condition of the uterus. So doing this correct diagnosis of the situation, we can choose the better way to solve the problem. How can we solve the problem when we find it? So we can do a lot of kind of procedures. If you remember that I tell you that the uterus I divide in internal and external compartment. When we talk about internal compartment and its treatment, we can use the hysteroscopy. The hysteroscopy is a very good tool, is a powerful weapon. It consists in a cam, a small cam that we introduce inside the uterine cavity through vagina for vaginal route. We go inside the uterine cavity, and we not only confirm the diagnosis that we suspect with the ultrasound scan and the other imaging techniques, but we can also treat the problem at the same time. It's for diagnosis purpose and also for treatment purpose. Normally, we do in our center about 700 of these kind of procedures per year. That it's a lot of procedures, and we have a lot of experience doing these kind of procedures. And the procedure consists in 15 or 20 minutes of surgical time. We introduce the cam, and we use a small scissors and small forceps to cut and extract the pathologies and correct all the pathology situation that the uterus has inside. And after that, the patients need to recover for 1 or 2 hours from anesthetic recovery, and after that, the patient go home same day. Okay. The second weapon that we have to solve the uterine problems, in this case, in the external part of the external compartment, we have the abdominal surgery. The abdominal surgery have two kind of approach. The first one is the open or traditional or conventional surgery. As you can see here, the first scar is the open surgery consists in big wounds. Through this wound, we access to the abdominal cavity and also to the pelvis, and we fix problems in the uterus. This is a scar like a cesarean section scar, something like this. It's the same. And on open surgery, we do this other kind of wound. This is a vertical wound. Sometimes we need to do this kind of procedure to solve the problem inside the pelvis. This is the most frequent procedures that we do in open surgery. On the contrary, we have laparoscopic surgery. On the other hand, the laparoscopic surgery has a small wound, like you can see in red color, like this one. In this opportunity, we introduce a cam through the navel inside the abdomen by this way, and we shed all the pelvis, and also we can introduce in these small scars scissors or work elements to do the job inside the abdomen. So this kind of surgery have a lot of benefits to the patients because the recovery is absolutely more faster. Also, they have lower complication rates for sure, and we do this kind of procedure in our center in about 95% of the cases, even in patients with previous surgeries. And a big percentage of these patients, we do the surgery in the morning and the patient go home in the evening, same day. We do a lot of these kind of procedures. So this is the two kind of surgeries or abdominal surgeries that we can do, the open or laparoscopic one. So when we do a surgery, this is a question the patient always asks, and is how much time I must wait after the surgery to do the embryo transfer. So the answer depends of the procedure that you do in the uterus. So In our experience, when we do a hysteroscopic procedure, we must wait generally 2 months to do the embryo transfer. 2 months for complete the healing process inside the uterine cavity. And after that, we check the uterus with an ultrasound scan to see if the healing process is good. And if we see everything good, we do the embryo transfer. But normally we last 2 months to do the embryo transfer. And this is the first situation. The other situation is if we do an abdominal surgery, it depends of the surgery that we do. But generally it's more longer times of recovery to put the embryos inside the uterine cavity. So when we do surgeries to remove myomas or to do myomectomies, we always wait until 5 months to do the embryo transfer. Is the time that the uterine wall needs to heal very well and support a pregnancy. And if we do a surgery, an abdominal surgery to remove that tube, a fallopian tube, or to remove an ovarian cyst, maybe we can do the embryo transfer next month or in 2 months. It's more short time to do the embryo transfer. And finally, a take-home message. It's important to do a correct diagnosis of the situation of the uterus. And to do that, we need to support with the ultrasound scan. It's the best tool for evaluate these kind of problems. And a correct evaluation go for a good treatment of the pathological situations. We have two powerful weapons to solve the problem. One is the hysteroscopy and the other is the laparoscopy. And if we can use these weapons with faster recovery of the patient, we can treat almost all the uterine problems and improve the condition of the uterus for the pregnancy. And finally, if we can transform or treat a uterus with these conditions and transform in most normal uterus, we can cause the balance move to the gestational site. So finally, if you are interested in more details about our treatments and about our surgeries, you can see here we have a YouTube page to when we up all our surgeries. You can see this in YouTube. And that's it. Hope for questions, and I hope you enjoy the presentation.
And thank you so much indeed for presenting this interesting, providing all those details to us as well, and explaining how it works. Actually, it's definitely interesting. And as you can see, there are plenty of questions ready for you, Dr. Norman. So, well, are we ready to go ahead with the very first question that we have?
Yes.
Perfect.
We can answer the question. Yes.
There are some questions in Spanish for you as well, but I guess it's not so. But I guess we can, of course, show them as well. So just let us know a little bit on what is the question about. Okay, so we know. Perfect. Thank you so much. And let's have a look at the very first question that we received. I have fibroids. These are not inside the uterine cavity. Do I need to get them removed? My scans have shown and doctors have said they should not affect implantation, but now I am not sure whether to remove them, as I have had embryo transfer before, but they do not implant.
Okay, so we need to evaluate all the situation of this kind of uterus. There is consensus about which type of myomas we must remove to improve the pregnancy. So generally, all the submucous myomas, this is the myomas inside the cavity, we should to remove it. And from the outside part of the uterus, the myomas is located in this part of the uterus, the outside part. Maybe we don't need to treat, but in the middle, we have a myomas in the middle of the uterine wall. Sometimes it depends of the location of this kind of myomas and the size of this kind of myoma. Maybe we can treat this myoma. We can extract this kind of myoma. We need to evaluate the situation. If the patient already have an embryo transfer and failed with several embryo transfers, maybe we need to plan to extract the myomas. If the patient have previous failures, so it depends the situation. Is the patient consult without embryo transfers before? Maybe we don't need to remove the myomas. But if the patient has a lot of failures, we can remove it. It's better.
All right, understood. Thank you so much for the very first question. And actually, there is another part to the question, and we have just received that. So I have had hysteroscopy 2 years ago. My fallopian tubes were not blocked. Would I need to do hysteroscopy again? Since my last IVF I tried was 1 year ago, and I'm thinking to start a cycle again. Would there be that much changes in my body in 1 year?
Let me think. I don't see any relation about the hysteroscopy and the fallopian tube and to start a cycle again. There's no problem. You can start with the cycle. I don't see the problem to start with the cycle. You can do that and cut all the eggs, and you can have the embryos. And after you have the embryos, maybe you can check the tube again. And if you have endometriosis, it's also important to check the tube again, maybe. And if everything is okay, you can do the embryo transfer. But I don't see any problem to do a cycle again.
All right, understood perfectly. Thank you so much for answering those two questions already. And let's have a look. As I mentioned, next question will be in Spanish. So please let us know what's this all about, so everyone knows. And of course, please, thank you, Carmen, for your question, of course, as well.
Reglas. Okay. This kind of problem, I mean, in Spanish or in English? I don't
in
know.
English, please, of course, okay?
In English, yes, for sure. Okay. So, I see this kind of problem in a lot of patients. When we have this menstrual pattern, maybe we need to check the uterine cavity. Maybe we need to do a 3D ultrasound scan to see how is the morphology of the cavity. Sometimes the uterine cavity is small. It's very small. That's the reason why the patient bleed a few days during the menstrual period in some case. So the first way I recommend is to do an ultrasound scan and 3D scan to see the uterine morphology. And if the uterine cavity is narrow, we can improve the size of the cavity with the hysteroscopy.
And excellent. Thank you so much, Lucas, for your question. And let me have a look at the very next question that we have. As you can see, more of those questions are coming up. Next one is a little bit longer. I have adenomyosis and what has been described as burned out endometriosis. I also have a small fibroid. My last clinic said it was not a problem. No blockages of my fallopian tubes. I have had 3 failed donor egg transfers. I also have elevated NK cells and underactive thyroid gland and tested positive for MTHFR gene. My last clinic just wanted to carry on giving me lots of different medication. Would you suggest that I need surgery?
Okay. You have an important condition of the uterus. This is the adenomyosis. Adenomyosis is an inflammatory condition. It's like endometriosis inside the uterine walls. So the uterus with these conditions need to be treated before put the embryos, or at least we do that in our center. So maybe you can benefit from the surgery, but I need more details about the condition of the uterus. I mean, the uterine cavity, maybe the uterine walls. If you have a wall more thicker than the other one, we need to evaluate a lot of aspects of this kind of pathology, the adenomyosis. But for sure, we need to treat this kind of uterus. If you need a surgery, always in this kind of patient, we need to treat this kind of uterus with HNRH. You maybe need to receive some kind of treatment to stop the menstrual period during at least 2 months or 3 months, because the adenomyotic tissue is grow more with your hormones. If we stop your hormone levels with HNRH, maybe for 2 months, we can improve the possibility of pregnancy. But I need more details about this kind of stuff. But adenomyosis is very, very difficult to treat. We have a lot of experience treating this kind of uterus. And we also use HNRH treatment before put the embryos inside.
All right, understood, of course. And Claire has just added that she has already sent some images from my MRI scan to Dr. Crespo as well. So I guess it will be reviewed.
Yes,
as well.
Maybe we will see soon.
Of course. Perfect. Thank you so much for that. Okay, and let's have a look. There is another question in Spanish in regards to adenomyosis, I guess, as well. So have a look at it, please.
Yes, it's more or less the same question like before. We have, if we have an adenomyotic condition of the uterus, sometimes if the adenomyosis affect the morphology of the uterus, or create a synechia, or have a lot of cystic lesions inside the cavity, with the surgical treatment, we can remove part of the disease, and we complete the treatment with a HNRH treatment for 2 months, maybe.
Excellent. Thank you so much.
We can combine the surgical treatment with the medical treatment too.
Understood perfectly. Then once again, thank you. And let's have a look at the next question. It's in regards to the PRP. So is there a side effect on doing ovarian rejuvenation, scar tissue on the ovary? So of course, PRP, ovarian rejuvenation. Anything you can say about that?
Yes. Is the ovarian rejuvenation is the holy grail for the reproductive surgeons. Now we are talking about these kind of procedures, and we start to do these kind of procedures in our few patients, but only with experimental purpose. And when this kind of technique described is useful maybe for young women with premature ovarian failure, Means that a woman lost all the menstrual periods before the 40 years. This is a premature ovarian failure. So in this kind of patient, if we apply this kind of technique, we can maybe find something in the ovary, maybe, but the results are not convincing, not too much convincing, because when we start to do this kind of procedure, we improve the condition of the ovary in maybe 20% of the patients. We need to perfectionate this kind of treatment, but there is a possibility we can do that for sure, but it's not the best option. Today we need to explore more and study more about this kind of treatment to offer to the patients. I think most of the fertility centers do this kind of procedure with experimental purpose.
All right. Again, thank you so much, of course, indeed, for this. And let's have a look. There are like two. Yes, and of course, we have a comment. Yeah, in regards to the question from the same patient. It is about low ovarian reserve, of course. Okay.
Yeah, absolutely.
Let's have a look at the next question about hysteroscopy. There are like two similar ones. I heard the hysteroscopy is painful. Is that true? And can hysteroscopy cause any damage scarring?
Yes, absolutely. Yes, if you don't have experience doing this kind of procedure, maybe you can injure the uterus. You can cause damage to the uterus. Sometimes, if you do not respect all the uterine tissue inside the cavity, maybe you can have problems, scarring problems after the surgery. So, if you don't have too much experience, maybe you can cause a problem. It's very common in our community. The other thing is painful. Most of the hysteroscopy that we do in the operating theater. So we do under anesthetic conditions. So the patient don't feel any pain after the procedure. But sometimes we do hysteroscopy in office. Generally, in office we use more thin or more small cam. So generally, the patient tolerate well the procedure in office. It's a very common procedure. Normally, it's not. Maybe some pain like a menstrual period is possible, but it's not the worst pain in the world.
All right. Again, thank you so much. And there is a comment actually from the patient. In Canada, we are in office and with only ibuprofen.
Okay. Okay. Yes. Sometimes we do this kind of procedure. We reserve this for diagnose purpose to check the cavity before planning the surgery. Sometimes we do this in office. Sometimes we do in office for a second look of a previous surgery. So this is the most frequent situations in our particular center. But there is centers that do this kind of procedures all in office. I don't have to say nothing about that. But we see that, or my feeling is that if you do in office, maybe you cannot do a complete job inside the cavity because the patient is suffering during the procedure. So that's the reason why we cannot remove, for example, a big myoma, or for example, we cannot remove a septum sometimes because the patient has too much pain. So we need to stop the procedure. That's the reason, because we do for complex hysteroscopy, we do always in the operating room. Always. We only reserve the office for minor procedures. diagnose, and second looks.
And thanks a million for yet another question, of course, well, for your answer and comments here as well. And let's have a look about the hysteroscopy. Next question that we have. So can you have a hysteroscopy if you have had loads of surgery? I also have lots of adhesions.
Yes, yes, absolutely. Very good questions. When you have adhesions inside the uterine cavity, you mean inside the uterine cavity? I think so. So if this is the situation, the best tool to treat the adhesions inside the uterine cavity is the hysteroscopy for sure. And we do that. We do that. Also, I can tell you that we do when we do a lot of myomectomy. For example, if we extract for abdominal surgery, we extract maybe 20 or 30, 13 myomas from the uterine walls. We always do an hysteroscopy in second time, 2 months after this myoma surgery, to check the uterine cavity. And there's no problem. There's no problem to do an hysteroscopy after an uterine surgical procedure. No problem at all. We do that always.
And there is a comment from Michaela. I've had bowel removal.
Okay. Is the same patient? I don't know.
Yes, sorry, it's
what you're trying to
like
say
a
to me.
follow-up. It's the same, exactly the same patient.
Okay, okay. So if you have bowel surgery, the bowel is outside the uterine cavity, so you can access to the uterine cavity without any problem to find adhesions outside the uterine cavity, because you by hysteroscopy route you don't go inside the abdomen. So I don't see any kind of problem. You for sure can do the hysteroscopy after a bowel resection, for example. It's no problem at all.
Okay, again, thank you so much for that advice. And of course there is a thank you from the patient for you for answering right here. And let's have a look. Next question again, it will be from Salome and it is in Spanish. Let's have a look at it.
Okay. Okay, this kind of uterus, the patient asked me about Aquatus uterus. This is a kind of uterus that have the fundus more thicker than the other walls. So it's not only this kind of morphology. You need to know why the uterus have this morphology. Sometimes this kind of uterus maybe will relate to adenomyotic condition of the uterus. Maybe we can search for this pathology for an adenomyosis. That condition is that uterus have a arcuate morphology, maybe. And if this is the situation, we can treat the disease in part with hemorrhage, and also if you have a recurring implantation failure, we can do surgery to work in the fundus. And we also in this kind of surgery is not only to correct the morphology of the uterus, but also to create some scratch effect inside the endometrial layer. So sometimes we do this procedure to improve the implantation process. So that will be my answer about these questions.
All right, wonderful. Again, thank you for that and letting us know a little bit on what it's all about. And thank you for your question, of course, as well. And let's have a look. Next question we have is, I've had 2 laparoscopies and hysteroscopies and had endometriosis. I also had subserosal fibroids removed. That would grow every time I did my IVF cycles, but still kept miscarrying in my pregnancies. I'm now using a donor and surrogate mother, but my question is, should I have more surgeries to remove the subserosal fibroids?
Okay. The succerosal fibroids. No, I think no. The succerosal fibroids is we need to see the size of these kind of fibers, but generally these fibers grow from the external layer of the uterus, so generally do not affect the endometrial cavity. So if the fiber is too big that compress the uterine cavity, maybe we need to treat this fiber first. But in this situation, I don't see the indication for a subserosal fibroid to be removed. So I don't think that this can solve the problem that you have. We must search more details about this uterus to find another condition that we can treat. But for sure, this is if the myoma is a subserosal one, maybe this is not the problem.
All right, and as you can see, there is a follow-up. Yes, Angela has added.
Oh, that's the same. Okay, 5, 7. Fine. Okay. There are papers that describe in the literature when myomatous uterus, uterus with a lot of myomas, maybe these myomas can affect the of the green layer of the layer, and maybe can affect the implantation process. But there is no solid evidence about the fibers when we have subserosal fibers that we need to remove. So if all the fibers are outside the uterus and do not affect the uterine cavity directly or indirectly, maybe we don't need to remove it, even with this size.
And perfect. Thank you once more for that. And let's have a look. Of course, there is a thank you from Angela for you. And there is also a thank you from Salome, from our previous patient, for your answer. And let's go to the next question on the list. I am a patient with a desire for pregnancy who suffers from uterine myomatosis with the presence of a FIGO0 submucosal myoma or greater than 2 centimeters in their clinical surgical practice. When they perform hysteroscopic myoma resection, do they leave the myoma in the uterine cavity for spontaneous reabsorption? What conduct and treatment would you carry out? Thanks. Very good presentation.
Okay. It's an easy question. When you have a submucosal myoma, you can treat the myoma in lot of techniques. You have a lot of technique to remove the myoma. The most important is to disinsert the myoma and extract from the uterine wall. So if you extract the myoma from the uterine wall and extract from the pseudocapsula, and leave the myoma inside the uterus, but is released, totally released from the uterine wall, you can keep inside the uterus. The word is not reabsorption. This is not the correct word. The word is that maybe this release myoma inside the cavity with posteriorly the patient, the uterus can have contractions and maybe can spill out the myoma spontaneously. If you disinsert the myoma, all the myoma, and leave it inside the cavity, the most normal thing that we occur is that the uterus can spill out spontaneously by contractions. It's normal, but it's not never reabsorbs. No, I don't think reabsorption is the word. Maybe it's expulsion of the myoma. yes, this can happen. There is a paper that talk about that, a multi-centered study with myomectomy, and they always leave the myoma inside the cavity, and the myoma is still out with the uterine contractions after 1 month, maybe. This happens frequently.
All right, again, wonderful. Thank you so much for yet another question and another answer. And let's have a look at the next one. Would a transfer from a donated embryo be successful after a surgical hysteroscopy, laparoscopy to remove endometriomas and fix a malformation uterus from adenomyosis? And also, how long would be the time at the clinic until the surgery is done and the patient can go home?
I don't know. Let me think because it's too long. The question. Okay. Well. You mean if we do surgery from an hysteroscopy and laparoscopy too at the same time? You asked me about how much time you need to recover before you go home. I don't, or the question is how much time I must wait to do the embryo transfer. I don't really understood very well
Possibly,
the question.
but I guess we just need to wait a bit. Andra, if you can just simply clarify, yeah, we can always go back to this question as well. Someone is
Yes,
typing.
yes, it okay. Okay, I wait.
Yes, let's give it a second so we can have this. Oh yeah, okay. Yeah, would transfer be more successful after the surgery?
Yes,
Andra.
absolutely.
Mm-hmm. Okay.
Absolutely. The short answer is absolutely. Yes. If we do the surgical procedure in all these conditions that you told me, for sure we improve the condition of the uterus. So you will have a more higher percent of successful for sure.
And that's wonderful. Thank you so much yet again for this question and your help with it. And next question again, it's in Spanish. Let's have a look at this one.
Mm. Mm, okay. After the surgeries, this kind of treatment in the uterus is considered a pregnancy of risk. Yes, sometimes depends of the treatment that the surgical treatment that you do to the uterus. For example, if you do only hysteroscopy, there is there is no need to consider this pregnancy a risky pregnancy. But if we do maybe abdominal surgery to remove a lot of myomas, so you need to think that the uterus will have a lot of scars in the uterine wall. So yes, we consider this risky pregnancy. And the risk is that the uterine maybe if you don't wait the healing recovery, the 5 or 6 months after the surgery, maybe the pregnancy can cause that the uterine wall can break at some point in the scars, and this is risky. So we always advise to our patients when we do a lot of when we do myomectomies, multiple myomectomies, we recommend to do a cesarean section for finish the pregnancy to do not have a labor, long or prolonged labor, to put stress in during the uterine contractions. So we recommend to do a cesarean section to finish in this kind of surgery when we do myomectomy. But not all the surgical procedures define pregnancy as a risky pregnancy. Not all. It depends the surgery that you do.
And again, thank you so much for this. And next question is a short one. Are myomas and fibroids the same thing?
Yes, the same. We use the same words to define this. Yes, easy.
Wonderful.
The same.
Thank you for the clarification. Let's have a look at the next question from Karen. With laparoscopy, do the additional 3 incisions only typically happen if there is anything to fix? I don't have any known condition and have unexplained infertility. I did have ectopic pregnancy 1 year ago, resolved naturally. The doctor didn't suggest any further investigation, although I was offered laparoscopy to investigate right-sided pain following ectopic. However, wondering if hysteroscopy would be better and less invasive. Since then, I've had 1 round of IVF with failed implantation in case it helps to know. I am 42.
Okay. Yes. The ectopic pregnancy, resolve spontaneously. So normally when we have an ectopic pregnancy and we do not solve by surgery, we put a medical treatment or solve spontaneously, as you say. Maybe the tubes in this part of the uterus doesn't work very well. So maybe the tube is not working very good, and in sometimes we can accumulate liquid inside. It's like anhydrosalpines that I tell you. We must suspect that maybe the tube is not working well. Maybe we need to check with your previous ectopic pregnancy. It's important to check the tube. If the tube is correct, maybe hysteroscopy can detect other problems inside the cavity. If you have previous failure during the transfer. But you need to know you have 42 years old. You need to know also that maybe the embryos, the quality of the embryo is not the best. So this is other aspect that we need to take in account in this situation. Not only the uterus, but it's okay. It's okay. We need to get the uterus for sure, but also we need to think in the quality of the embryos in this case. But for sure, I maybe request some tubal test to see how is the tube, how is the condition of the tube, and if the condition is bad, we remove this kind of tube before to proceed with the embryo transfers.
All right. Again, thank you so much for yet another answer. And let me, go straight to the follow-up from Karen, same patient, okay? I have had hycosis 6 months later and liquid flowed through both tubes, but liquid could not be seen passing through the right tube, only spilling out.
Okay, but is the liquid is spilling out from this tube? For sure, this tube is it's working. Maybe it's working. Let pass the liquid from inside the uterus. So before we do the embryo transfer, when we do the preparation of the endometrium to do the embryo transfer, we need to recheck with the ultrasound scan, because maybe when the tube let pass the liquid, but it's still not working very good. So in sometimes in this situation, we can see accumulate of liquid. It depends on the phase of the endometrial preparation, and we can detect again another problem in the tooth. But if you tell me that they do ECOSY and it's good the test, I think that the tooth is maybe not the problem.
All right, and thank you so much for that. And there is a thank you from Karen for you as well. And there are like 4 or 3 questions left. We will be slowly finishing, but of course, if you have any left, go ahead and type those in. And let's have a look at the next question in Spanish from Maria. Here it is.
Okay. In these situations, when we have an hydrosalpinx, but the liquid can pass, by definition, the hydrosalpinx is the tube is not working, so it's obstructed in the terminal end of the tube. So that's the reason why the hydrosalpinx generate. That's the reason why the tube accumulate liquid inside, because it's obstructed at the end part of the tube. So sometimes when we do the endometrial preparation to do the embryo transfer, we sometimes can see hydrometra is liquid inside the uterus, but we don't know where is it coming this kind of liquid. You only need to check the tube, and if the tube is more thicker and with liquid inside, definitely you must remove the tube before put the embryos inside, because the probability of pregnancy is lower with this condition.
And perfectly understood. Again, thank you so much. And we will go back to the previous previous question in regards to high COSY. If you can have a look, is a high COSY better than HCG, or is it HCG is better? Does one give better results than the other?
Yes, very good question. Very, very good question. Yes, it depends of the experience of the doctor that do the test. Um, for me, it's better to do the hysterosalpingography, because you in the hysterosalpingography you can check the tube perfectly. Is for me, it's better, and with the ECOSY, you depend of your ability with the ultrasound scan to check all the trajectory of the tube, If the tube are normal, it's easy to interpret this kind of study, the ECOSY. It's easy. But if the tube has surrounded by endometrial disease or surrounded by adhesion, sometimes even if the tooth is permeable, you can miss a diagnosis with ECOSY, because it's difficult to interpret it in pathologic situations when the tooth is distorted in all the trajectory. So for me, it's better to request an HSG. HSG is better. The ECOSY, it depends the experience, but I always prefer the ASG.
And excellent. Thank you so much yet again for this question and for answering and explaining this to us as well. And let's have a look. Next question. I lost my menstruation early due to stress. It's been over a year since. I have never got pregnant. However, I am healthy and I'm not overweight. Did an ultrasound scan and was told that I have low AMH, 2.1 picomole, FSH 112.5. I want to use my own eggs. I read about PRP. You have talked about this today as well. Can this help? I am 40.
Yes, the PRP is now using in a lot of specialties. the PRP, there are a lot of studies that are trying to improve the ovarian response using this kind of compound. The theory tell us that the PRP have a lot of growing factors that we can use to improve the growing of the follicles inside the ovary. This is the theory. But right now, we are using few times this kind of therapy. Is only for experimental purpose. I see the anti-Mullerian hormone and FSH level tell me that the ovary is not working very well at all. And this is related to the age. So my best advice in this situation, maybe we can do a cycle, maybe to see how is the behavior of the ovary administrating the hormones, and if the ovary do not respond, maybe my best advice is to do an embryo an egg donation program.
All right, of course. Thank you so much for that advice as well as your answer. And so, yeah, sure.
Yes, I must tell you that it's not impossible. It's not impossible. 40 years old with these hormone levels, it's not impossible to have an embryo, but it's a difficult way. You can use the PRP too, but it's for experimental purpose. And yes, maybe it's not the best way to do.
And thank you once more, of course, for this. And let's have a look at the next question. Two parts of the question. I had failed IVF transfer last week. I have stage 4 endometriosis and did a laparoscopic surgery in June. I did intralipid well 6 days before transfer. Is there perhaps a reason my transfer failed? And the follow-up here is I had one fallopian tube removed also, and my lining was 9 millimeters 10 days before transfer day. Anything you can advise?
Okay. And a surgery with endometriosis stage 4 is okay. Is you have a lot of disease, so they removed only one tooth. What happened with the other tooth? Maybe if the other tooth is not working fine, maybe the tube can be the answer in this case. But I don't know. I need to see more details about the case. How old are you? And I don't know if the age of the patient is here. I don't know. Because this is one aspect that we need to take in account, and the other is the condition of the uterus. If you have an endometriosis in stage 4, for sure, you have an adenomyotic condition of the uterus, for sure. It's always linked with this kind of stage of the disease. So if you have any kind of problem inside the uterus, maybe we can do a hysteroscopy, or maybe we can treat the uterus with the NRH before do the embryo transfer.
Okay. Sorry, there are just some comments from the patient. Still have the right tube, side tube, and she is 31. Sorry, 31.
31. So very, very young patient. Okay. So because your age, the quality of the embryos maybe will be good, but also in endometriosis, the quality can be affected of the quality of the embryos, because the eggs grow in an inflammatory environment inside the abdomen. So when we extract the eggs, maybe can reduce the quality of the embryos. But this is not all the problem. Maybe we need to search more about the uterus, about the condition of the uterus. They remove a lot of disease, as you told me, and we need to check the uterine itself, the uterine cavity and the uterine walls, because sometimes we need to treat the uterus before put the embryos inside with medical treatment.
All right. Once again, of course, thank you so much for this yet another question and yet another answer as well. Next question again, it will be in Spanish from Maria. Let's have a look at it.
Okay. A challenging question because if you have already the embryos, or if you go for an spontaneous pregnancy, if you don't have pain, the pain is the principal symptom that we need to take in account to do the surgery. If you have a bad quality of life, maybe we need to do the surgery before the pregnancy, maybe. But I don't know the symptoms of that you have. If you tell me that only have this disease, these findings in the MRI, and nothing more, and you don't have any kind of symptoms, and you already have the embryos, or you are planning to get pregnant spontaneously, maybe if you don't have nothing more than the findings, you can go for the pregnancy for sure. But if you have any problem like so much pain, or you have symptoms in the relate to the bladder, maybe we can do the surgery to relieve all the symptoms before get pregnant. It depends on the symptoms.
All right, of course. Again, sorry, there is a follow-up from Maria. Okay, right here.
Okay. Okay.
And here.
Okay. Okay. So, okay. Well, if you have this kind of, okay, and you also check the tubes, I insist with the tubes, because when you have cysts in both ovaries, maybe the tubes are affected too. So you must take in count of the tubes also. If the tubes are in bad condition, you need to remove it before putting it inside, because it can affect the implantation process when the tubes are in bad condition. But you need to check first. This is my advice. And if you have the embryos and you tolerate very well the pain and everything, first I treat the condition with NRH maybe before put the embryos inside, and then or after the treatment we put the embryos. And if you get pregnant, you must remember that the pregnancy itself is a condition that put the endometriosis in pause, maybe. I don't know how to say, put the endometriosis in rest during 9 months. So is the pregnancy itself is good in an endometriosis situation, because you stop the menstrual period during 9 months. So maybe can improve the symptoms, maybe. So if you can tolerate very well the pain and the symptoms, you can go ahead with the pregnancy. Oh, you have an idiosapiens. So my advice is to remove the idiosapiens before putting them inside.
All right. Again, thank you so much for your question, Maria, and of course for answering this one as well and letting us know a little bit about the question, of course, as well. Okay, let's have a look. We will be slowly finishing. There are like 2 questions left, and the next one is from Claire. Do you recommend having an endometrial scratch before transfer, or would you say this is not necessary?
Okay, the there is a lot of controversies about the endometrial scratch. There is some groups that do not believe in this kind of treatment. It's okay. It's okay to not believe in that. But there is other group that have a very good result doing the endometrial scratch. So the endometrial scratch was described for implantation failure, for recurring implantation failure. So if this is the situation, maybe you can benefit from the endometrial scratch before put another embryo. For example, if you already put 3 or more embryos inside the cavity, and all the time you have a negative result, maybe you can benefit from an endometrial scratch. It's possible to in this kind of situation. But if you never have put an embryo or have transferred an embryo in your uterus, it's not the first option to do an endometrial scratch.
And wonderful again. And Claire has added, I had a scratch on the first and second transfer, but didn't have it on the third. No implantation at all on my transfers.
Okay. So they do. I don't know what they do exactly. But well, if you tell me that you already have 2 endometrial scratch, maybe the problem is in another part. Maybe the problem will be the embryos. We need to pay attention to other elements in the pregnancy equations, like the quality, and the age of the patient, or if you have a recurring implantation failure, maybe to do a genetic test of the embryos, DGP, before put the embryos inside again to test the embryos. We need to see other variables in this equation. Maybe the problem will be the embryos and not the uterus. I don't know.
All right, again, thank you so much for this. Understood. And there is a thank you from Claire for answering this question, but she previously has added as well. Thank you for answering all my questions tonight. Very interesting presentation. Thank you for that. And let's have a look now. It seems that this is our final question for tonight. So, do you continue to lose eggs during the 9th months of pregnancy?
It's very, very, very good questions. Yes, very good question. There is a growing. There is the ovaries continues growing inside. Have 2 phases of growing of the follicular growing or the eggs growing. The first step of the growing follicles are not dependent of the hormones of the NRH and FSH and LH. It not depends from the gonadotropins to grow up. So that's the reason why during the pregnancy you stop all the ovarian stimulation from your brain, So you stop producing NRH and FSH and gonadotropins because the hormone levels, the estrogen and progesterone, but the cycle of growing inside the ovary is continued. It's like when you take the contraceptive pills. When you take contraceptive pills, you stop the hormone influence from the brain, but you are still losing eggs during the time that you use the contraceptive pills. I don't know if I will. It's a very complicated concept to understand, but you must need to know that there is two steps for the growing of eggs. The first step, it not depends from for your brain, for the hormone of your brain, and the second step, it depends for the hormone of your brain. So always, if you stop the brain, the hormone production of the brain, always the ovary is still growing inside from the first step of the, I don't know, the follicle development. So yes, the short answer is, I think, yes, you will lose eggs during these 9 months. It's like when you take contraceptive pills.
All right. Thank you so much indeed for
It's the
answering
same
this question
for the
as well. And there is thank you, of course, from good to know from Karen here as well. And as I mentioned, that was our final question. So thank you everyone for joining us for tonight. That's first, but also for all of your questions. Definitely interesting. And thank you so much, Dr. Norman, for also being with us and simply joining and spending our this evening with us and providing so many details and useful information. It's been a pleasure to have you here. And before we finish, anything else you would like to add? As you can see, more things coming up your way.
Yes, no, I want to say again the thanks for the opportunity to show you our daily work and part of our work. And I have nothing more to say. That thank you again for you, Caroline,
Wonderful.
and the all the patients that ask me a lot of things about the treatment. I appreciate that, and I like all the questions. So thank you.
Thank you indeed. And as you can see, again, more of those information coming up. Very informative presentation. Couldn't agree more, really. Thanks for answering all the questions. And I just want to mention again that this has been recorded, so you will have a chance to watch this again if you would like to. And you will be able to find it on myivfancestors.com, but also on our YouTube channel. It will be available there tomorrow. And of course, you know, we will be back here tomorrow and day after tomorrow. So I do hope to see you back here as well. And Dr. Norman, thank you for this once again, and have a lovely evening, everyone. And Dr. Norman, till our next event as well. Okay.
Okay, thank you.
Wonderful. Thank you so much. Take care, everyone. Have a lovely evening. Thank you a lot. Bye.
Bye. Bye.